Okay, let me move on. And, um, Mark, um, I'm a leukemia doctor because I've only had to deal with giving 2 drugs at once, and that's all I can do. 7 and 3, 40 years of that. And now we're talking about triplets over the doublets. I feel like they're trying to make me a myeloma doctor. It's making me very, very anxious. But what's your thought about adding in FLT3 inhibitors to HMA-VEN or HMA with a FLT3 inhibitor alone?
So we've been wrestling with that a fair amount. Obviously, we know that a FLT3 mutation, you don't respond as well or you don't respond for as long with an HMA-VEN combination. However, we've already just spent all this time talking about the myelosuppression with aza-ven, and it's real. FLT3 is important for normal marrow to reconstitute. That multipotent progenitor cell has FLT3 on it. It wants to regenerate all those nice neutrophils and start that process. You inhibit FLT3, you are going to impair that. And when we combined gilteritinib with venetoclax, we saw some profound aplasions. So what we've been doing at my institution is a little bit different. We will pop the patient into remission with aza-ven if they have a FLT3, and then we actually sequence with aza-gilt, and then we go back to aza-ven. So we actually, I don't like using that triplet. I recognize that's a great interest. A lot of people say, of course, it's perfectly safe to do. That hasn't been quite our experience with the profound aplasias. So that's been our approach. I don't know the answer.
Yeah, I agree with you, Mark. The triplet can be very myelosuppressive. I've had experiences where I give the aza-ven, I clear an IDH clone only to be left with a FLT3 clone, and then give gilteritinib, and kind of had to almost bounce between the 2 regimens because it's hard to give them at the same time.
Yeah, so we've been sequencing aza-ven, aza-gilt.
Yeah. So before we leave this combination, any final thoughts about HMA-VEN that you want to bring up? Any of you?
I would like a cautionary tale to not sound like we want to be advocating tons of mixing and matching, because I think that it's really hard to do sometimes. And I think that we are a victim a bit of our own success in having a lot of these drugs available. And I worry actually that it's going to be very hard to learn what to sequence and how to change these doses and schedules if everybody kind of just makes it up. And I philosophize about this a little bit because I'm not sure what the right answer is. I mean, we're in the middle of COVID, people can't get to centers. You want to try to do things that make sense. You have a smattering of data from here and there. So I understand that, and I do that too. But at the same point, I think it's going to actually be very difficult for us to answer the fundamental questions of which triplet, and is it an IDH inhibitor up front, or is it venetoclax up front, or are you alternating between them, or is there some kind of, is one of the agents to be continued indefinitely? It's really hard to answer this if we don't do some studies.
Right. Gail, I'm gonna come back to you when we get to the IDH inhibitors for that very thought about the triplet combination there. Dan, I think you want to add something.
Actually dovetails nicely with what Gail said. And something you said earlier, that, pay attention to that plateaued curve at the end. And let's dig into who those patients are and how, what has made them be able to have this very long-term remission. And let's learn about who those people are, and if they are people whose disease is being driven by a FLT3 mutation, then let's add a if they are not the patients with a FLT3 mutation, then those are patients we should probably be leaving alone. And so understanding who those patients are and leaving them alone and giving them this very potent and reasonably well-tolerated, reliable therapy is the way to go. And then learning who the patients are who aren't staying in these long-term remissions, and doing something like what Mark said makes a lot of sense to me, sort of alternating therapies and sort of pushing on one clone versus another to try to prolong the remission. But like Gail said, I would really discourage just throwing everything in at the beginning, because you can see there's a 20, maybe 30% of patients for whom that will only represent over-treatment and excess toxicity.
Dan, that dovetails into the question I wanted to ask you. You presented previously data from the the HMA-VEN combination with clearance of leukemic stem cells. So my question for you is there any data from any of the venetoclax data that a deeper remission, an MRD negative CR, means anything more than an MRD positive CR? Is there any difference in survival that we know of between those two qualitatively different CRs?
Not that I'm aware of at this time, but I will say that I don't think that the appropriate studies have necessarily been done to answer that specific question, but in the very near future, that is an extremely relevant question that we need to answer.